as effective as our therapies are in first line and subsequent lines, still a large number of patients do not respond at all. They have innate resistance, or they respond and then unfortunately they have recurrence or progression of their disease. So it depends on what therapy they received in first line. We have the decision to make about what therapy we will treat that patient with in the second line. So if in the scenario where patient is receiving or has received a first line therapy with an anti-VEGF agent, such as pazopanib or sunitinib, those are the two most frequently prescribed or have been the most frequently prescribed first-line anti-VEGF agents. When patients progress on one of these two agents, the choices were or have been to go with an immune checkpoint inhibitor, so going from target therapy to immune checkpoint inhibitor therapy. Nivolumab was FDA approved in that space in November 2015 based on the Checkmate 025 study showing improved survival compared to everolimus, which had been an FDA-approved agent in the salvage setting post-sorafenib or sunitinib. But there are other choices in that space. So after progressive disease with a first-line tyrosine kinase inhibitor such as pazopanib or sunitinib, one can treat a patient with cabozantinib or lenvatinib and everolimus. So these are the three FDA-approved therapies for second line after a first-line TKI.
The combination of lenvatinib plus everolimus is an FDA-approved combination in the second-line setting after progression on a prior TKI. Lenvatinib is a multi-tyrosine kinase inhibitor inhibiting VEGF-R 1 through 3 and also FGFR 1 through 4, among other kinases including PDGF and RET protein oncogene. In this setting, it broadly targets multiple receptor tyrosine kinase inhibitors. mTOR is a nexus to integrate growth factor and nutrient signaling, to which it takes information from the growth factor signaling from the receptor tyrosine kinases in order to control growth and proliferation. The combination of the two mechanisms likely provides some type of synergism or at least additive effects in order to improve outcomes. In order to overcome resistance, mTOR inhibitors have been added to lenvatinib plus everolimus, or been used in combination with lenvatinib. mTOR mutations or activating mutations within the mTOR pathway are actually relatively few and can't fully explain the clinical responses that we see to mTOR inhibitors. Therefore, it also plays a critical role in probably the resistance mechanisms that may be downstream of other growth factor signaling. Lenvatinib targets two key pro-angiogenic growth factors, including VEGF and FGF. Together, this seems to provide a mechanism by which to overcome resistance that can be seen with just inhibition of VEGF signaling alone.